General factors. I'm just going to give a broad perspective. So each topic itself is a separate lecture. Very huge area, but just I want to cover on a case-to-case basis some interesting cases. Based on interesting cases, I will show you the application in the routine practice. So the main advantage of ultrasound is non-radiation. X-rays are radiation. So my today's talk will be on the advantage of ultrasound, the disadvantage, and what kind of preparation you require to run ultrasound, and clinical exams I will show you. The advantage is it's easily available and it's cost effective. It's very less expensive than a CT scan or an MRI, and it takes less time. There is no radiation. The specificity is good, but sensitivity is less when compared to CT scan. CT scan will pick up vision better than ultrasound. But once the ultrasound fixes the vision, then there is definitely a 100% specificity. So the disadvantage is obesity. When you are obese, the ultrasound wave doesn't pass. The fat is a bad conductor for ultrasound. So it reflects the ultrasound fat. So any structure below that fat will show very poor quality images. So in an obese patient, the image quality is poor, so your diagnostic capacity also becomes poor. The next is air. Air again will never allow the ultrasound to pass, which is reflected in air. So you cannot do scanning of ultrasound of chest. So there is a fluid collected between the lung and the chest wall. Then what is a good conductor for? So through that, through the patient, you can see the add some consolidations in the physical, but not frequency. So for chest, only to detect fluid diffusion, you can do an ultrasound. Otherwise, it is not useful. So because of that, our bowel contains a lot of gas. So the bowel pathologists will not be able to pick up an ultrasound, except certain, like for example, a large mass or appendix can be picked up in most of the cases. But sometimes even the appendix will not be picked up on this. And it's operator dependent. So it also depends on the experience of the operator. So how to manipulate, how to do it in a proper way, and the machine also. The machine you have a very cheap to very high-end machine. So based on that high-end machine, you get a better result. So all these things are the disadvantages. Preparation usually 4 to 6 hours faster. Why you are asking for fasting? Because after having food, the gallbladder will contract, will release the bile. So if you are fasting, the gallbladder will open up. So any stores in the gallbladder will be picked up only on fasting. That's the reason we always ask for come on fasting. Then urinary blood has to be filled. Why we ask urinary blood to be filled? Because ultrasound conducts the through the fluid in a very good, very well manner. So you are able to see the uterus and all is better when the blood is full. If blood is empty, what happens? The oil of the small bowel are pushed down the appendix and blood is collapsed. So there can be gas in the bowel. So because of the gas, you are not able to see the uterus and oil properly. For that reason only, we are asking the patient to become blood full so that bowel will be pushed up out of the pelvis, so we are able to see the uterus and oil better. So always important that blood has to be full. And color Doppler of like for artery and venous flow, we do color Doppler. So for that, we have to ask a prayer appointment. It takes much longer time to do it. So other patients with full bladder they will wait. We cannot wait them to wait. It's very difficult for patients to wait in full bladder. They will finish the doctor. So always better to take the point from doctor. So coming to abdominal application, this is the most common application of ultrasound. So wherever you do, whenever a patient has got any acute abdominal pain, or chronic abdominal pain, or any recurrent abdominal pain. So any kind of abdominal pain, ultrasound is an indication. Then patients with indigestion and loss of weight, any bleeding in the urine, hematuria, or any urinary tract infection, or any vomiting with blood, or any case of fever, So all these things are indication for ultrasound abdomen. I will show you some of the examples of this. So here is a patient with acute pain in the pelvis, pelvic pain, and a young woman. So what are you suspect? Young woman, you will suspect one thing, it could be a pregnancy outside the uterus and it's ruptured ectopic pregnancy. Other could be an ovarian cyst which is twisted to a torsion, ovarian torsion. Or it could be an abscess, ovarian abscess, or uterine tract infection, or appendicitis also can have appendicitis. So all these differential diagnoses are given. So ultrasound will be able to differentiate these conditions. So one of the conditions like urinary tract infection is more of a clinical diagnosis, but sometimes urinary tract infection could be due to reflux. So all these things can be due to ultrasound. So here is an example. The transvaginal scan shows a ovarian abscess. So it's a right ovarian abscess the patient has, and that's the cause for the pelvic pain. And patient also has some kind of fever. So this is another example where patient has again pelvic pain with positive pregnancy test. So any young woman with pelvic pain, you have to do a pregnancy test. Do a pregnancy test. If it's positive, then we should suspect ectopic. So in ultrasound, here are two examples. One example is a live ectopic. You can see the heart pulsation here, and this is a ruptured ectopic where the ectopic is ruptured and there is a blood in the pelvis, hemoptysis. So this is a classic. So this is an example. A young patient vague abdominal pain. So vague abdominal pain, and retrospectively, she had history of close contact with dog, like dog pets, and this is classical hydatid cyst of liver. So the patient was very close contact with close pets like dogs. They can have a disease like this, hydatid cyst of liver. So which can be easily diagnosed in ultrasound. Again, alcoholic patient with present with fever and abdominal pain. So any patient with a fever and abdominal pain, look, here this is a very classical liver abscess. So any chronic alcoholic patient, they will always can have a liver abscess. You have to be cautious about it. So there here another patient present with loss of weight and loss of appetite. Okay. So as ultrasound was done, you can see multiple hypo. We call this hypo large ones are called hyperpigmentations. So hyperpigmentation, you will think of metastasis. So that primary will be from the stomach or from any part of the body, which has got metastasis to the liver. Again, patients with the history of chronic alcohol, always you have to see how the liver is. So when you will be doing blood test to see whether the liver enzymes are okay. Suppose the liver enzymes are elevated, then you ask them to do ultrasound. So ultrasound will help you to see how much is the fibrosis. First, initially the patient will have fatty deposits in the liver. So we call it fatty liver. So next to the fatty liver, there will be stage 1 fibrosis, stage 2 fibrosis, stage 3 fibrosis, then cirrhosis. Cirrhosis is finally the shrinkage of the liver. So this is the case where you have fatty liver here. Fatty liver, the liver should normally not be as bright as this. This is the kidney. So it is very much bright. So if you have something bright, then it's a fatty liver. Then you see the cirrhosis where you can see the fluid in the abdomen, and the liver bottom shows nodularity, irregular, wave-like pattern. So this is the cirrhosis. In between these two stages, we have got fibrosis stage. For that, we have gone on to the liver elastography. So liver elastography is a technique where we measure the stiffness of the liver. Normally, liver is very soft. So when the patient keeps on taking alcohol, slowly the stiffness increases because of fibrosis. The stiffness increases. So based on measuring the stiffness of the liver, we are able to stage the liver. Stage 1 fibrosis, 2, 3, and 4. So it's very useful. You can reverse back. Fatty liver can be reversed, and the fibrosis when it's set in, you can keep the same stage 1 fibrosis. So it's useful for treatment for such patients. Once they go for cirrhosis, then there is no option. You have to do a liver transplant. So this is especially indicated in chronic orthopods, liver elastography. And post-hepatitis, some of the patients who get developed hepatitis, they will go for cirrhosis in the future. So such patients also can be followed with liver elastography to see how the liver stiffness is. So a patient again presenting with fever and jaundice. If there are any patients with fever and jaundice, could be obstructive jaundice where in the bile duct that is obstruction, or it could be bile hepatitis. So how we can differentiate those two in ultrasound? In obstruction, we can see the stone in the bile duct, cystic duct. We can see that. If the non-obstructive bile hepatitis, you can see the gallbladder. This is the gallbladder. The gallbladder wall is thickened and there is fluid around the gallbladder. So this finding you will get in bile hepatitis. So we will be able to say that this cause could be due to bile hepatitis. So most of the patients will get commonly like indigestion and upper abdomen. That could be due to peptic ulcer. If you keep treating for peptic ulcer, patient doesn't get cured, and then you have to send for ultrasound. That could be because of the stones. So this is the gallbladder. Here you see a very clear wall of the gallbladder. The previous bile hepatitis, the gallbladder wall was irregular, thick and edematous. So, but here you see a stone. This one is bright, echogenic thing is the stone. Okay? You can see it under the same stone. So these gallbladder stones can cause indigestion. There could be multiple stones. Sometimes stones will be so many numbers, all overlapping each other, you will not be able to count and tell how many stones. Sometimes you cannot measure all stones. If it is a single stone or one or two stones, you can measure the stones. If it is multiple, you cannot measure it. So the same patient later on present with severe abdominal pain. Okay. Then when the patient with severe abdominal pain, already you have done a scan, you have got gallbladder stone or severe abdominal pain, you have to suspect that the gallbladder has got infected. So here again this is a stone and the gallbladder has got infected. You can see the walls, gallbladder walls thickened, and you are not able to see the gallbladder wall and it is sedimented. So this is acute persistent where the gallbladder is got infected. Here, this is an example of patient presenting with the right lower abdominal pain, the right leg fossa. So, when you have pain in the right leg fossa, you suspect that could be an appendix. So, when you send for appendicitis, you can see classically the appendix, you can see a thickened appendix in a medial fashion, and in the cross section, you will see a rounded hypo. That is black, white, black, gradient line. This is a very classical appearance for acute appendicitis. Again, a patient presenting with indigestion and loss of weight. So when there is loss of weight, you always look for some malignancy. Malignancy could be either the liver, or it could be stomach, or it could be gallbladder, anywhere. So in this patient, there is this mass. This is the gallbladder. There is a mass around the gallbladder. This is the gallbladder malignancy. Some of the alcoholic patients will present with severe abdominal pain and excessive pain related to back spine. There is severe pain on the back. So such patients can have acute pancreatitis. So acute pancreatitis, again you will do a blood test. The serum lipase amylase is released. Then you send for ultrasound. The pancreas will be enlarged like this and it will appear black. Normally pancreas will be whitish in color. But here, because of the inflammation, it's black, it's enlarged in size, and there's a lot of fluid around the pancreas. So, acute severe epigastric pain, it could be pancreatitis, it could be peptic ulcer, it could be gallbladder stone, or it could be reflex gastroesophageal reflux, or it could be aneurysm, which is leaking. So, all these things you can diagnose except peptic ulcer, which you cannot diagnose the ultrasound, and GE reflex again you cannot diagnose. So this is a case of acute pancreatitis. So moving to another example where you have history of lentility. A lot of times like people will be playing football, cricket. You will have an injury, ball will come and fall on the stomach. Or sometimes while playing, somebody will hit on the stomach and force. Or while driving some train, you will fall on the. So blunt injury abdomen is another silent killer. You will not know what is happening inside. Okay? There will be bleeding inside. So it is better that right in the abdomen you should send for an ultrasound and check out for any laceration or confusion in the liver, spleen. So these confusions will slide, especially spleen, when it will bleed and patient will die without we knowing what's happened. Outside the lungs, there is already a collapse. These are a case where this is spleen, there is a severe laceration happening in the middle of the spleen. You can diagnose splenic injury, liver injury, kidney injury, and blood injury in the abdomen, and bowel injury. All this can be diagnosed by ultrasound. So any blood in the abdomen, you have to be very cautious. Keep it in mind that these patients need investigation. Just say, okay, you are fine. You pass, send them home, and they will collapse. So the most common findings often we get in the practice is pain radiating from the hip to the scrotum in this fashion. Okay? So from the right loin to the scrotum. Those are costly because of stones. So here is an example where you see this is a bladder which contains fluid. Any fluid contains a tube of black. Because ultrasound passes fluid, it doesn't get reflected. So you see that stone which is bright at the UV junction, uretrovascular junction, this is stone here, this is stone. So again stone, you can pick up in the kidney, you can pick up in the ureter. So this is another common cause for patients presenting with severe pain. Patients have very severe pain. They will have vomiting, sometimes diarrhea, sometimes total pain. So different types of pain they will present. And sometimes only the smaller stones they will have more pain. See, the largest stone they will not have pain because the reason is the largest stone will come and will stay in the ureter for a longer time at one place. It will move slowly. When the stone moves slowly, there will not be pain. Only when the stone moves, there will be pain. When the stone is not moving and staying at one place, there won't be pain. So sometimes you will be surprised, like big stone will be there, patient will not have any pain. But a small stone, the patient has severe pain because it is continuously moving. Okay. So again, these patients will have everything. So here is a patient presenting with hematuria. So when a patient presents with hematuria, blood in the urine, you have to suspect it could be a cancer, it could be a stone, it could be urinary tract infection. Okay. The cancer can be in the bladder or it could be in the kidney. So anywhere. So on ultrasound here in this case, I have showed a cancer in the bladder. Okay. So next moving on to the patient like severe bleeding during menstruation. So a lot of ladies will be coming with this thing. So when they have severe bleeding, the cause could be either a fibroid, it could be endometrial hyperplasia, it could be an endometrial polyp, it could be thyroid, hypothyroidism or hyperthyroidism, or hormonal imbalance, estrogen, progesterone hormone. So the hormone imbalance is one thing which we will not be able to diagnose. Other things we will be able to diagnose. Here is an example, there is a big fibroid. So this fibroid is pressing on the endometrium. Because it is pressing and it is expanding the endometrium, the patient will have severe pain. So the other important thing is patient present with pain during menstruation. You will be commonly getting this patient, pain, severe pain. The main causes it could be adenomyosis or endometriosis. These are the main important causes. So what is endometriosis? Right? It is the endometrial tissue, secreting tissue which gets secreted in the ovary, and in every menstrual period it starts bleeding into the ovary. So that's the endometrial cyst which will form a cyst and inside will be blood. So the patient will get pain. Another thing, the endometrium, what happens to the adenomyosis? The endometrium tissue will move into the myometrium. So once it moves in the myometrium, the patient has got severe. That's called adenomyosis. Sometimes you get fibroids also pain, and sometimes you like to put copper in. Some patients will have pain with copper. So that was an example of endometrial cyst. Here you can see a cyst with fine internal, not a clear fluid. It is like if you take a look at the system that within the last endometrial cyst. This is a very bright ovarian cyst. So very bright ovarian cyst is a diamond cyst. So these diamond cysts, what happens sometimes it twists. It will twist along itself and the vascular supply will be cut off, so it will also be affected. So again, ovarian torsion because of the diagnosis, the most common in your clinical practice will get very young patients. Nowadays it's very common, irregular periods. So that is the polycystic ovary. Polycystic ovary has become very common. We don't know the reason. Previously it used to be obese ladies, obese young children. They used to have. Now even we are seeing thin babies. A lot of kidney diseases also are got in polycystic ovary. We don't know what exactly the reason for that. So this is a classical polycystic ovary. You will see multiple tiny cysts in the periphery of the ovary. The ovary will be rounded in shape and they will have antibodies. This is very classical picture of polycystic ovary. It's very common cause for infertility and irregular periods. The other common cause is the thyroid. These two are the very most common for irregular periods. So next moving on to the other area. These are the abdomen is the most common area for ultrasound. Next is the scrotum. A lot of babies, young male child, they have scrotum pain. Even adults also will have scrotum pain. That is one indication. Then sometimes infertility patients, they come when you check for the pains, they will have less sperm count. That's other indication for scrotum. Then some males will come with a big scrotum. Other indication for scrotum. So some of the example, a patient with big scrotum. So you can see the testis, and another testis you will see the fluid. As I said, fluid allows ultrasound to pass through, so it will appear, fluid will appear black, and this is the fluid around the spot. So here again a patient presented with pain to scrotum, and this is spermatic cord area, and spermatic cord is thickened. So this is a condition called urethritis, infection of the spermatic cord. Again pain, the epidermis, this is the testis, this is the epidermis. The epidermis will be enlarged, thickened, and it will show increased color. That's called acute epididymis, is another form of infection. Then you have patient present again to have pain abdomen. Here the opposite scrotum will show the color flow. The affected scrotum will not show color. If there is no color flow inside the scrotum, it is torsion of testis. The testis gets twisted and the vascular supply gets cut off. So patient has severe pain. So this you have to differentiate whether it is due to infection or whether it is due to torsion. Torsion means you have to do surgery and you have to decause it. Twisting has to be released, then only the patient will get it. If it's infection, you just give antibiotics, scrotum support, all that. So next is the male patient presenting with low sperm count. The cell for ultrasound. You see here, these are dilated. You see dilated veins. Dilated veins in the scrotum. So if you see this is a varicose vein. Because of this varicose vein, the patient's sperm count comes down. So you treat this, the sperm count will improve. So this is very common. And again, you can have a pregnancy, the testis. There are so many other conditions. Testis itself is a big topic. I'm sure the common ones. Next, on neck ultrasound, any neck swelling, you can send for ultrasound. And neck pain, these are more common. So here is a patient with thyroid swelling. So you see a cyst, colloid cyst we call this one. And you can see a lot of multiple nodules, different findings in thyroid. So all these things can be confirmed with the FDC or biopsy of the lesion. And under ultrasound, you can provide evidence. Remove the small bit substance and send for the testing. Here the patient is presenting with the swelling in the cheek area and pain. So when they put ultrasound, you see small black areas, dot, acute curtain. And another patient again presenting with this burden of purgatory cheek area. You have an abscess here. This is an abscess, the purgator. Then another patient having while eating, he gets swelling underneath in this area, that is submanual gland area or purgator area. So they get swelling while eating, then you think that to be stone obstructing the flow of the saliva. So because of that, gland swells. So here this is the submanual gland, and this is the dilated gland. Consider dilated gland, and here the stone. Because of the stone, that's an obstruction and the stone. This is submanual gland stone. Like that, you can get that stone. Submanual gland stone. So next it could be I talked about peritonitis infection, peritonitis abscess, then it could be tumor. Tumor can arise in the peritonic submanual, like tumor, carcinoma, virgin tumor, that tumors also can be diagnosed. So these are common ones. Next again thyroid, gland and lymph nodes. Lymph nodes many times you get large lymph nodes. You can do a scan and you can do an FAC. And the evidence will be what, whether infection or the tumor or infection. Moving on to breast, which is again common. Patient with breast lump or painful breast. Some of the examples here is an example where the lesion is well defined. It is well defined, mostly benign, non-cancerous. So this is a fibroadenoma. This is non-cancerous. This one, you have a irregular, you don't see the margins over here. So this is a malignant cancer. So once you know it's a cancer station, you can put a needle, take a biopsy and send for histopathology. So, and that is some patients will have a vague lump and they will present there is a pain during menses or intramenstrual pain in the breast. So such patients, if you do a scan, can see this is good cyst, but many times will be very tiny cyst, small cyst, multiple cyst. Those are benign, but it's called fibrocystic disease of the breast. So you see most of them on both sides. Then some of the lactating women, like breastfeeding women, they can have an abscess in the breast. So this is a condition where there is an abscess. So move on to the third appropriation. Third appropriation mainly to see the blood flow in the arteries. We have diabetic, chronic diabetic patients. You will have the flow in the vessels all will narrow down, and the blood flow to the vessels, the artery, to the limbs will get reduced. So to direct that, whether there is a flow to the arteries, the limbs, many times you get ulcers in the foot. So the ulcer in the foot is because of the less blood supply to the area. So especially the toe, the greater toe will get an ulcer and sometimes it will be black. So you do a card after and see how much blood flow is going on. So if the blood flow is less or there is a block, then you can clean it up. So sometimes the patient now unilateral swelling of the limb. That could be because of thrombosis of the veins. The veins can get thrombosed and you get swelling of the legs and they will have pain also. So again, for that you will do a compress. Then doctor of every vessels we do, especially when the patient is about vertigo or diseases, to see any block or narrowing in the artery. So when you see any hypertensive patient, so there could be a renal artery problem. Renal artery could be narrow or renal artery stenosis. So for young patients, when have hypertension, you have to go to a renal doctor to see whether renal artery is high. So leg swelling again could be deep veins or could be due to varicose veins, the dilated veins, you can see loose colored veins, dilated ones in the legs. So when it is there, you go to a doctor and see where there is a leak coming from which vein, so that you can clean it up. This is an example of a vein doctor. You can see veins shows blue color, and artery shows red color of the whole. So Apart from this application, we have a needle guided procedure. You can do a for fine in aspiration for cytopathy, which is in needle 12 hours. Or you can do a biopsy, which is bigger needle. And there's an abscess or any fluid anywhere, you can put it in an aspirate. And apart from this, we here in our center we do a lot of things. Like if you have multiple pregnancy, 3 or 4, we reduce 2 and make it 2. Sometimes the patient also have to, with the already have one side, so I don't want to future, I will reduce 1 to 1. So this is considered needle. The needle is coming from here, just inside the position and there will be the pregnancy. These are done on the So other very common applications which we use in this scan is the pregnancy scan. Pregnancy scan to confirm the pregnancy that we do at 1000 weeks. We do anomaly scan to pick up any abnormality at 1000 weeks. Then we say how the baby is doing at 10 weeks. These are the common scans which we do with the time of pregnancy. And then if there is any necessity, we do it more frequently. Thank you. So these are the main landmarks, and this wedge-shaped area is the costophrenetic angle, and this is the cardiophrenic angle. This one, this is cardiophrenic angle. This is costophrenetic angle. The importance of this has to be sharp V-shaped. If there is some blunting, that means there could be some pleural fluid inside. So because of the pleural fluid, this part could be operated. Okay. And this part could be operated because of some mass or something behind the heart. This cardiophrenic angle, this is the diaphragm. This is part of the diaphragm. So moving on to the zones, various lobes. So you draw a line on this second rib, anterior part. This is anterior part of the first rib. This is the anterior part of the second rib. You will draw a line in the lower part of the anterior part of the second rib to the opposite side. Anything about this is called upper zone. Then second line will be second rib, third rib, and fourth rib. So below the fourth rib, you draw another line. So between the second rib and fourth rib, anterior part, this is mid zone. Then you below everything below that is called the lower zone. So when you describe a finding, you can say it's upper zone, mid zone, lower zone, like that. So why we are not using lobe? Because you see the upper lobe almost comes to this much. It covers the upper, mid and lower zone. Okay. Then lingual lobe. Lingual lobe covers again mid and lower zone. Then lower lobe will cover upper, mid and lower lobe. So it's very difficult to say by lobe. The lesion is in the upper lobe, middle lobe, lower lobe, because there is an overlap. So to make it easy, we have made this upper, mid and lower lobe. Okay. I hope you are able to get that clear. In the left lung, there is only 2 lobes. There is upper lobe and lower lobe. That's no middle lobe. And there is a lingual lobe. There is a small lobe. Okay. So for a practical approach for writing a chest radiograph is just remember, lung is usually blackish. So white lung is one part of the disease, dark lung is another part, and cystic lung. So remember these 3: white lung, dark lung, and cystic lung. Okay. So lucid line, right? That's the like instead of midline, it has shifted to one side. Okay. The heart and hiatum, everything is shifted to one side, to the left. And this lung is herniating. Other lung is herniating to the left side. Why is doing that? Because the left lung has collapsed. Because of the collapse of the left lung, the mediastinum, that is the heart, is pushed to the left, and the right lung is compensating hyperinflation and is being pushed to the left. So this is the complete collapse of lung. So when you want to decide whether it's a collapse or not, you have to look at the tracheal position. Trachea has to be shifted to the same side, the collapse. Look at the right lung. So what is better and push to the left side. And mediastinum again is shifted to the collapse side. So these things will take collapse consolidation. This is not happen. So that's how we can differentiate consolidation and a collapse. So differential diagnosis is, as I said, consolidation, where these three things will not happen. And in fluid efficient, what will happen? Again, these things will not be allowed to shift. Okay, the shift will be the opposite, but not the shift. So that is the total collapse of the left lung. I have showed you total collapse of the entire left lung. Here I am showing collapse of the right upper lobe. Okay. In collapse, usually the lung will be very bright. Whereas in consolidation, there will be uniform amount of air will be there within the shadow. So it won't be as dense white as this in a consolidation. So again, this is collapse. Another finding is the margin of the collapse will be very sharp. In consolidation, this will be sharp, it will be lazy. The margin of the collapse will be sharp and highly dense. There won't be any air bronchograph, that is lucency within the opacity. So again, the differential is consolidation and lung mass. So as I said, the differential point is between dense opacity and sharp margin. These are two, which is visible and collapse. Again, another case where there is right lower lobe collapse. Here the shadow, you can see the diaphragm very well here. Here you don't see the diaphragm. So clearly. And this is a right hilum, which has to be on this side. The right hilum and pulmonary vessels are pulled down because of the collapse. So once there is a collapse, there is all the structures moving clearly. This is another condition where there is a collapse here. This collapse is difficult to diagnose because its heart is white, the collapse is white. So you have to look for very carefully whether there is a very dense shadow behind the heart. So here actually in a PowerPoint it's not seen very clearly, but I am able to see the example. Same way you will find it difficult. You have to put it the log, X-ray log. Without X-ray log, you just see that in a tube brain you will miss this kind of collapse. That's the Here I am saying an example. The patient will come with cough and fever and X-ray chest. Let's say subtle opacity here. Okay. This is the minor fissure, which is seen normally, and this opacity is very subtle. Only when you get a good quality X-ray, you can pick up this kind of thing. So it's always you have to go for a digital X-ray rather than the older X-ray. Go for a digital X-ray. That's a done properly. Then you can pick up these kind of pneumonic patches. Here another case where you have opacity. This is not a dense opacity. You can see some loosened areas in the opacity. This is how you differentiate from the collapse and a consolidation. So consolidation, pneumonia are one of the same. It's not due to infection, bacterial infection. So this again opacity bilaterally, typical opacity is seen on both sides. You can see some full diffusion here. The CP angle is obliterated. Here also the CP angle is costophenic angle is obliterated. So bilateral full diffusion. So the opacity is on either side in the main in the hilum. So this is cardiogenic pulmonary edema. So the patient is in failure. So pulmonary edema we have bilateral findings. It's called Bradley sign. So here is another, you can see a central opacity with a small cavity. You can see a opacity with a small cavity. You see any opacity with a cavity, it's tuberculosis. Tuberculosis is a very common. They have a cavity with surrounding opacity. So other cases also can have cavity, like fungus infection can have a cavity. Sometimes medications also can have. But in India, common any opacity with cavity, you have to think of Okay. So the main problem is sometimes you think there is opacity and you think there is consolidation, you give antibiotics or you give whatever treatment for the patient. So it doesn't resolve, even with all kind of treatment. Then you have to think that would be the case. So this is the same thing which the patient was treated for an infection. It didn't resolve. So then we went ahead with the chest CT and FLAC was done from this and got a malignant lesion, cancer lesion. So again, there is a lesion in the right hilum, large opacity there. So again, you have this differential diagnosis. It could be a pneumonia or it could be a malignancy. So CT chest, there is a mark which is infiltrated in the pulmonary artery. So this causes the carcinoma. So apart from this, there are some chronic conditions. Patients will get exposed to a lot of asbestos and mines, the sand mines and plastic industry. A lot of things are around Coimbatore. We have this cement factory. So when they are exposed to that, they can develop something called interstitial lung disease. So in interstitial lung disease, you will get linear opacities. Linear opacities everywhere in both the lungs. The patient will have difficulty in breathing. Some asthma-like condition is presenting, but it is not truly asthma. These are all fibrotic strands happening in both lungs. And when you do a CT, you can see classically, you have seen the fibrotic strands everywhere. So this is the classical interstitial lung disease. So you have to be suspect in cases who are exposed to industrial work like cement factories and mines and all. So now we have finished about talking about the bright lung. Now we will move on to dark lung. So dark lung, the most common is emphysema. So emphysema is a condition which commonly occurs in long time smokers. And again pneumothorax, again included in smokers, and any injury to the chest to get pneumothorax. So here is the lung. You can see instead of 6 vertebrae, you will see more of anterior part of the vertebra. The lung is so expanded, and the diaphragm is usually instead of this curve, it will be little flattened. The diaphragm will be flattened, the lung will be overexpanded. You will see more ribs, anterior part of ribs, and you will see the vessels are very less. See, you can see especially here in this area, the vessels are very less. Yeah, can you see that? The vessels are very less here, and here also the vessels are less. So this is emphysema. So when you have a long time smoker, so the lung, inside the lung, it will get out cyst-like conditions, and in X-ray you will see as a dark lung. And only when the X-ray quality is good, you will be able to appreciate this, otherwise you will not. But CT will definitely show you better. This is a case of pneumothorax. What happens is, there is a sharp hole in the lung due to external injury, any fracture of rib, to cross section to the lung. So the lung will start collapsing as the air is leaking from the lung into the throat cavity. You can see the lung has collapsed here. You can see the air. We don't see any vessels here. You can see the vessels here, but we don't see any vessels. This is pneumothorax. The lung is getting collapsed. This is the part of the lung, and all these things are air outside the lung. That's pneumothorax. This is called tension pneumothorax. Immediately you have to release. You see something tension pneumothorax. You put in a needle and connect a tube and put it in a jar with water, and another tube will have come from the water jar outside, so that all these airs will go into the water and the lung will start expanding. So this is an emergency. So tension pneumothorax is an emergency. So if you are able to pick it up, it's good for the patient. So this is the dark lung. So I said bright lung, dark lung, and cystic lung. The cystic lung, the most important thing is the bronchitis. Bronchitis is a condition where the bronchi, which is a tubular structure like pipe, it becomes cystic. expanded and cystic appearance like a bulge like that. So most of the times X-rays will not show it. So best is the CT scan. Here in this case, we are able to see can you see the small cyst? Can you appreciate? Okay, small cystic lesions. So very subtle in X-ray. So if you see the cystic lesions, this is classical bronchitis. So the same patient, HRCT, it's very easy. You can see a lot of cysts. This is a normal plant. Here you can see a lot of cysts. So this is classical cystic bronchitis. So the take-home message is, remember, white lung, large lung, cystic lung. Most of the times you will get white lung only. It will be infection, it will be malignancy. So dark lung and cystic lungs are quite less common. And picking up an X-ray is quite difficult unless you have got a very good quality X-ray. Thank you. Lights. Light on. Come on, light on. So that is about the COVID. Yeah, that is mainly done on HRCT. It's not done on X-ray chest. So you have to do HRCT, then you see depending upon the ground mass capacity, the scoring. So up to 25, what is the score? It's not X-ray test. So that is totally different. The COVID positive patient, and you send for CT scan. In CT scan, we have a score based on the ground mass capacity. Which are lobes are involved, how many lobes are involved, how much is involved, like that. Based on that, we have the parts. That's a total different topic. HRCT itself is a big topic, HRCT of lung. So it will show much more than what X-ray shows. So that's a different topic. Some information like where some patient may ask you what will be the radiation I get after single chest X-ray. It's around 0.1 millisieverts. Okay, so that is like normally you have background radiation. So even outside when you walk, you have a background radiation. So it's like 10-day you are normal, like 10-day radiation. What you will get in a one chest X-ray. Okay. So it's like on flight journey from Coimbatore to Chennai or Delhi, we give the almost similar radiation. So let's say 1 day. So suppose you are coming from Kerala, you get much more higher radiation. Background radiation is very high in so the radiation into a chest X-ray is very less. Generally people will ask how much radiation will be saved. Any other question on X-ray chest? Okay. I think Prakash, sir, coffee is no telling soon. 10:15. 10:15. 10:15 is one. Okay. So I'll move on to other topics.
ಒಂದು 20 years back got dengue. அந்த dengue விடுத ஒரு ஸ்கேன் பண்ணேன். ஆக்சுவலி நான் வர முடியல, சாரி, லேட் ஆகிடுச்சு. இருந்தாலும் உங்களுக்கு ரொம்ப தேங்க்யூ ஃபார் ஆல். அவ்வளோ தூரம் டாக்டர் உமேஷ் பாலஸ் வந்திருக்காரு. தேங்க்யூ. ஓ, தாராபுரம். தேங்க்யூ. சார் ஒரு
it's nice to see you all coming from far away from Dharapuram and Kolam. It's amazing. And as Sir said, we had a long-term relationship, and Actually, we have been doing it for last 23 years, quality work. So most of my patients reference are also for quality. And we'll do this often, and you have given some suggestions. So maybe once in 2 months you can do for as you whatever topics you like, you can do it same like 1 hour or 2 hour sessions in morning. Thanks once again. Nothing else to. Thank you, sir. Thank you. I'm very honored.